Aloha and welcome to the Hawaii VFC Virtual Office Hours this Tuesday, January 14, 2025, brought to you by the Hawaii Vaccines for Children program. Today's session is being recorded and will be available on our VFC website on the link on the screen. If you haven't been receiving emails regarding VFC updates, important notices, and other VFC-related information, and would like to be added to the Hawaii VFC program email list, please email your request to hawaiivfc@doh.hawaii.gov, and please write email list in the subject line. If you are watching this recording and have any questions, please email them to hawaiivfc@doh.hawaii.gov. Here are the objectives for today's webinar. Provide an overview of Neisseria meningitidis and its potential to cause serious diseases like meningitis and septicemia. Discuss the various types of meningococcal vaccines available through the Hawaii VFC program for administration to VFC-eligible patients, and understand best practices for storage, handling, and administration of these vaccines to ensure efficacy and safety. What is meningococcal disease? It is an acute severe illness caused by the bacterium Neisseria meningitidis. The two most common types of meningococcal infections are meningitis and septicemia. Meningitis is the inflammation of the membranes covering the brain and spinal cord, while septicemia is a bloodstream infection, also known as meningococcemia. Symptoms of meningococcal disease can first appear as a flu-like illness and rapidly worsen. The overall case fatality ratio for meningococcal disease is 10 to 15%, even with appropriate antibiotic therapy, and can be higher in persons with meningococcemia. As many as 20% of survivors have permanent sequelae, such as hearing loss, neurologic damage, or loss of a limb. And although most people will make a good recovery, some will be left with life-changing after effects. So the babies and young children are most at risk, and the next most vulnerable group is teenagers and young people. So Neisseria meningitidis is an aerobic gram-negative bacterium classified into 12 serogroups based on characteristics of the polysaccharide capsule. Almost all reported cases of the meningococcal disease worldwide are caused by one of the 6 serogroups A, B, C, W, X, and Y. The relative importance of serogroups depends on geographic location and other factors such as age. So between 2011 and 2020, in the United States, serogroup B caused about 60% of cases among children younger than 5 years old, and serogroups C, W, Y caused about 2 out of 3 cases in people aged 11 years or older. Serogroup A is rare in the United States, thanks to the vaccines, because historically, the serogroup A was common in the sub-Saharan Africa, but has been nearly eliminated right at that meningitis bout. So how is it transmitted? Meningococci are transmitted person to person by respiratory droplets or secretions from persons with asymptomatic colonization or meningococcal disease. The bacteria attach to and multiply in the mucosal cells of the nasopharynx and oropharynx, which is the nose and the mouth, and in small proportion, much less than 1% of persons, penetrate the mucosal cells and enter the bloodstream. The bacteria can then spread through the blood to cause systemic disease and cross the blood-brain barrier into the cerebrospinal fluid, or CSF, to cause meningitis. So the signs and symptoms of meningitis and septicemia. For meningococcal meningitis, it is an abrupt onset of fever, headache, stiff neck, altered mental status or confusion, nausea, photophobia, or eyes being more sensitive to light, and vomiting. And symptoms in babies appear to be slow or inactive, irritability, feed poorly, bulging fontanelle, bulging anterior fontanelle or the soft spot of the skull, abnormal reflexes, and vomiting. While the symptoms of septicemia is the abrupt onset of fever and chills, cold hands and feet, diarrhea or nausea with or without vomiting, fatigue, rapid breathing, severe aches or pain in the muscles, joints, chest, or abdomen, petechial or purpuric rash, often associated with hypotension, shock, acute adrenal hemorrhage, and multi-organ failure. So the surveillance data released on November 2024 by the CDC shows that rates of meningococcal disease have risen sharply in the United States since 2021 and now exceed the pre-COVID-19 levels. That's why it's important to ensure that everyone who's recommended to receive meningococcal vaccination is up to date. Now let's talk about the meningococcal vaccine recommendations. There are 3 types of meningococcal vaccines that are licensed for use in the United States. And this protects 5 serogroups. First is the MenACWY, which protects individuals from 4 serogroups ACWY, MenB, which targets serogroup B, and MenABCWY, which is the combination vaccine that targets 5 serogroups A, B, C, W, and Y. First is the MenACWY vaccination. So there are 2 kinds, which is the Menveo and Menquadfi. The Menveo is supplied in 2 presentation, the 2 vial presentation and the 1 vial presentation. The 2 vial presentation, a vial with a MenCWY 135 liquid conjugate component, which is in a gray cap, and a vial containing Men-A lyophilized conjugate component in orange cap. The contents of the vials must be combined to form Menveo prior to administration, so you have to reconstitute this one. The 2 vial Menveo presentation is not routinely distributed by the CDC and is considered a special order vaccine. It will only be supplied to VFC providers who have high-risk VFC-eligible patient aged 2 through 23 months for whom it is indicated. So VFC providers must contact the Hawaii VFC Program to request this vaccination. And the 1 vial presentation of Menveo, which is in a pink cap, does not require reconstitution before use and is for use for individuals 10 through 18 years of age. Menquadfi is another kind of MenACW vaccine, and it is supplied in 1 ready-to-use vial and no need for reconstitution. It is indicated for 2 through 18 years of age. And just a note, when more than 1 brand of MenACWY vaccine is age appropriate, they are interchangeable. Who are the eligible groups for ACWY vaccines. These are the children aged 2 months through 10 years who are at an increased risk for meningococcal disease attributable to serogroups A, C, W, and Y, including children who have persistent complement component deficiencies, including inherited or chronic deficiencies in C3, C5 to C9, properdin, factor H, or factor D. Children taking a complement inhibitor, for example, eculizumab, ravulizumab, and children who have anatomic or functional ischemia, including the sickle cell disease. Children infected with HIVs are also included as the increased risk. And children traveling to or residing in countries in which meningococcal disease is hyperendemic or epidemic, particularly if contact with local population will be prolonged. And children that are identified at high risk because of an outbreak of the meningococcal disease, attributable to serogroups A, C, W, or Y. And all children aged 11 through 18 years of age. So just a note, in addition to meeting the specified indications for vaccination, VFC supplied vaccines may only be administered to VFC-eligible children. For MenACWY routine vaccination, it is administered as a 2-dose series at age 11 to 12 and another dose at age 16. ACWY vaccines may be administered simultaneously with MenB vaccines if indicated, but at a different anatomic site if feasible. For the catch-up vaccination, if the vaccine is administered at age 13 to 15, 1 dose is recommended and another booster at age 16 to 18 years old, and the minimum interval is 8 weeks. And if the MenACWY vaccine is administered at age 16 to 18 years old, the patient is only recommended 1 dose. For the Hawaii school vaccination requirement, MenACWY vaccine is required for 7th grade attendance in Hawaii. It is also required for students entering grades 7 to 12 for the first time in Hawaii, as well as for first-year students living in on-campus housing. Special situations for administration of MenACWY vaccines. For people with anatomic or functional ischemia, including sickle cell disease, HIV infection, persistent complement component deficiency, and complement inhibitor, Menveo, dose 1 at age 2 months, is required 4 doses. So it is administered at 2 months, 4, 6, and 12 months. Dose 1 at age 3 to 6 months, 3 to 4 doses. 3 to 4 dose series is are recommended. So dose 2 and dose 3, if applicable, at least 8 weeks after the previous dose until a dose is received at age 7 months or older, followed by an additional dose at least 12 weeks later and after age 12 months. Dose 1 at age 7 to 23 months, 2 dose series. Dose 2 at least 12 weeks after dose 1 and after age 12 months. And if dose 1 is administered at 24 months or older, 2 dose series is recommended at least 8 weeks apart. MenQuadFi, dose 1 at age 24 months or older, 2 dose series at least 8 weeks apart. Another special situation Those who are traveling to countries with hyperendemic or epidemic with meningococcal disease, including countries in the African meningitis belt or during the Hajj. There's a link over there for more information. So children younger than age 24 months, Menveo for 2 to 23 months of age, dose 1 at age 2 months, and it's again a 4-dose series, which is given at 2 months, 4, 6, and 12 months. Dose 1 at age 3 to 6 months receives 3 or 4 dose series. Dose 2 and dose 3, if applicable, at least 8 weeks after the previous dose until a dose is received at age 7 months or older, followed by an additional dose at least 12 weeks later or after 12 months of age. If dose 1 is administered at age 7 to 23 months, 2-dose series is recommended. Dose 2 at least 12 weeks after dose 1 and after age 12 months. For those children traveling to places with meningococcal disease, children age 2 or older, 1 dose of Menveo or Menquadfie is recommended. As a special situation for first-year college students who live in residential housing, if not previously vaccinated at age 16 or older, or military recruits, 1 dose of Menveo or Menquadfie is recommended. Adolescent vaccination of children who received MenACWY prior to age 10 years. Children for whom boosters are recommended because of an ongoing increased risk of meningococcal disease should follow the booster schedule for persons at increased risk. And children for whom boosters are not recommended, administer MenACWY according to the recommended adolescent schedule for dose 1 at age 11 to 12 years and dose 2 at age 16 years. Special situations booster dose recommendations. Individuals aged 2 months and older who remain at increased risk, and completed the primary dose series or series should receive a regular booster dose. So for children under age 7, administer a booster dose 3 years after completion of the primary series and every 5 years thereafter. And for children 7 years and older, administer a booster dose every 5 years. So children aged 10 or older may receive a single dose of Penbrea as an alternative to separate administration of MenACWY and MenB when both vaccines would be given on the same clinic day. For contraindications and precautions, you may be able to see the details on the link on the screen. MenB vaccination. So on October 24, 2024, the ACIP updated its recommendation for MenB vaccination. This is pertaining to Bexsero. They wanted to align the dosing interval and schedule with the FDA label and harmonize with recommendations for Tremenba vaccine. So these are the MenB vaccines. Bexsero, which is manufactured by GSK, and Tremenba, which is manufactured by Pfizer. So there's a note in here that MenB vaccines are not interchangeable by manufacturer. Administration of a B component vaccine requires that subsequent B component vaccine doses be from the same manufacturer. So the same vaccine product must be used for all doses in a series. So if you started with Bexarel, the next and final dose should still be Bexarel, and the same thing for Trumenba. The eligible groups to receive Men-B vaccines. These are children aged 10 to 18 years at increased risk for serogroup B meningococcal disease, including children who have persistent complement component deficiencies, children taking complement inhibitor, children who have anatomic or functional asplenia, including the sickle cell disease, children identified to be at increased risk because of a meningococcal disease outbreak attributable to serogroup B. And this is also recommended for children 16 to 18 years who are not at increased risk for serogroup B meningococcal disease, may also be vaccinated when shared clinical decision-making favors administration of Men-B. And again, VFC supplied vaccines may only be administered to VFC-eligible children. So adolescents not at increased risk age 16 to 18 years based on shared clinical decision-making, Exero or Trumenba, please use same brand for all doses. The recommended dose is a 2-dose series, at least 6 months apart. If dose 2 is administered earlier than 6 months, dose 3 at least 4 months after dose 2. To optimize rapid protection, this is, an example is for students starting college in less than 6 months. A 3-dose series, 0, 1 to 2 months, and after 6 months may be administered. The link will on the screen will take you to information about shared clinical decision making for Men-B. So if Men-B vaccines may Men-B vaccines may be administered simultaneously with Men ACWY vaccines if indicated, but at a different anatomic site if feasible. Another special situation for Men-B vaccination, patients who have anatomic or functional asplenia, including sickle cell disease, persistent complement component deficiency, and those who are using complement inhibitor. Bexarel or Trumenba is recommended as a 3-dose series at 0, 1 to 2, and 6 months. If dose 2 was administered at least 6 months after dose 1, dose 3 is not needed. If dose 3 is administered earlier than 4 months after dose 2, a 4th dose should be administered at least 4 months after dose 3. So children aged 10 years or older may receive a dose of Pembrea, which is a combination vaccine for Men ACWY and Men-B. They may receive Pembrea as an alternative to separate administration of Men ACWY and Men-B when both vaccines is indicated on the same clinic day. For age-eligible children not at increased risk, if Pembrea is used for dose 1 Men-B, Trumenba should be administered for dose 2 Men-B. For age-eligible children at increased risk for meningococcal disease, Pembrea may be used for additional Men-ACWY and Men-B doses, including booster doses, if both would be given on the same clinic day and at least 6 months have elapsed since most recent Pembrea dose. Booster dose for Men-B vaccination for children at increased risk due to complement deficiency and complement inhibitor use or functional or anatomic asplenia. A booster dose is recommended if it has been at least 1 year since primary series and repeat every 2 to 3 years as long as risk remains. And for children at increased risk due to a serogroup B outbreak, booster dose recommended if it has been at least 1 year since primary series. If recommended by public health officials, booster dose may be given if it has been at least 6 months since primary series. And booster doses are not recommended for adolescents who are not at increased risk for meningococcal disease. For contraindications and precautions, please refer to the link. Combined Men-ACWY and Men-B vaccination. So the new pentavalent meningococcal vaccine, which has a trade name of Penbrea, was recommended by the ACIP in October 2023. Men-ABCWY helps protect against 5 types of bacteria that causes meningococcal disease, and this is Men-A. Serogroups A, B, C, W, and Y. Who are the eligible groups for Penbrea administration? So these are children who are children aged 10 through 18 who are at increased risk for meningococcal disease attributable to the 5 serogroups, including children who have persistent complement component deficiencies, children taking a complement inhibitor, and children who have anatomic or functional asplenia, including sickle cell disease. And it is also recommended for children aged 16 through 18 years for whom both Men-ACWY and Men-B are indicated to be given at the same time and shared clinical decision making favors administration of Men-B. So again, in addition to the specified indications for Penbrea administration, VFC supplied vaccines may only be administered to VFC eligible children. Children not at increased risk. Initial dose of Penbrea may be given in lieu of Men-ACWY and Men-B when both vaccines are indicated in the same visit. And shared clinical decision-making favors administration of Men-B. And the second dose, the Men-B series, should be completed with treatment. Children at increased risk. Primary series for children with persistent complement deficiencies, complement inhibitor use, or functional or anatomic asplenia who are due for both Men-ACWY and Men-B vaccination. 1 dose may be given in lieu of the first dose of Men-ACWY and Tremenba. If subsequent doses of Men-ACWY and Tremenba are indicated less than 6 months after the first dose, the vaccines should be given separately according to the Men-ACWY and Men-B recommended schedule. For boosters, for subsequent doses, where both Men-ACWY and Men-B are indicated, and at least 6 months have passed since administration of the previous dose of the Penbrea. Penbrea may be used. And now let's talk about the storage and handling of the meningococcal vaccines. So all of the types of meningococcal vaccines are stored at 8 degrees Celsius or 36 to 46 degrees Fahrenheit. So starting off with Menveo, for the packaging, it is supplied in two presentations. The 2 vial presentation has a gray cap and orange cap vials. So the gray cap contains the Men-CWY-135 liquid conjugate, and the orange cap vial contains Men-A lyophilized conjugate. And this one, again, requires reconstitution. And the 1 vial presentation of Menveo is supplied as one ready-to-use pink cap vial in packages of 10, and reconstitution is not required. This is administered as a 0.5 ml intramuscular injection. So do not freeze this one. Store in the refrigerator at 2 to 8 degrees Celsius or 36 to 46 degrees Fahrenheit. Do not use the vaccine if it has been frozen, and you need to contact the manufacturer for guidance and viability determination. Protect from light and administer the reconstituted 2 vial presentation immediately, or store it up to 8 hours and discard if not used. So I have the link here for the package insert of Menveo if you need more information. For the Menquad-V, it is supplied in a single dose vial in packages of 10. It is also administered as a 0.5 ml intramuscular injection, and the same thing as Menveo. Do not freeze and contact the manufacturer if it has been frozen. Do not use after expiration date. Package insert for Menquad-V is also available on the link. Bexsero. So Bexsero is available in 0.5 ml single dose disposable pre-filled Luer lock syringe in a carton of 10 syringes. And this is packaged without needles. This is to be used with Luer lock compatible needles. This is an IM injection as well. And same thing, refrigerated and do not freeze. Contact the manufacturer if it has been frozen. Protect from light and do not use after expiration date. Package insert is on the link. For Tremenba, it is supplied in a 0.5 ml pre-filled syringe, 10 per package. Also administered as a 0.5 ml IM injection. The special thing about Tremenba for storage is you need to place it in the refrigerator horizontally. It should lay flat on the shelf to minimize the redispersion time. And before using it, you need to shake it well to obtain a uniform suspension, making sure that it's combined properly. And do not freeze, and contact the manufacturer if it has been frozen. For Penbrea, it is supplied in a kit that includes a vial of lyophilized Men-ACWY component. It is a sterile white powder, a pre-filled syringe containing the Men-B component, and a vial adapter. So it needs to be reconstituted. Instructions for reconstitution is down here below, and it is also available in the package insert on the link. It is as well administered as a 0.5 ml intramuscular injection and stored in the refrigerator at 2 to 8 degrees Celsius. Do not freeze. So after reconstitution, administer immediately or store between 2 to 30 degrees Celsius or 36 to 86 degrees Fahrenheit and use within 4 hours. Next one will be ordering VFC meningococcal vaccines. So the meningococcal vaccines available for ordering through the Hawaii Immunization Registry or HIR are the following: the Menveo 1 vial presentation, Menquadphy, Bexaro, Trumenba, and Penbrea. It is important to note that the 2-vial presentation of Menveo is a special order vaccine not available through HIR. It is only supplied to VFC providers who have high-risk VFC-eligible patients aged 2 to 23 months for whom it is indicated. And to be able to request for this vaccine, VFC providers should contact the Hawaii VFC Program via email at hawaiivfc@doh.hawaii.gov. Sorry, I missed the gov right there. Or by phone at 808-586-8300. We did webinars regarding VFC vaccine ordering and shipment. And to access those recordings, please click on the link below. For HIR technical or login issues, please contact the registry help desk at the numbers listed on the screen, as well as via email registryhelp@doh.hawaii.gov. And for general immunization questions, please call the Hawaii Immunization Branch at 808-286-8349. And for any VFC-related questions or concerns, please contact any member of the VFC QA team. So we are listed under the VFC program and VFC site visits. And the VFC vaccine ordering team is also listed in there in case you have questions about your vaccine orders. So we do have a post-webinar satisfaction survey. So we would greatly appreciate it if you can fill out the survey on the link. And thank you for taking time out of your busy schedule to join today's session. We hope you have a wonderful rest of your day.